Hello, Steve. We are doing a presentation today on pediatric shock, recognizing it before the crash. Hello, my name is Virginia Purdy. I am a paramedic instructor with Blue Ridge Community College. So this is the third time that I have recorded this presentation, so I'm optimistic that this time it actually will upload correctly. If not, you may be getting a text from me, Steve. So we are talking about pediatric shock. So when we talk about the differences between our pediatric patients versus our adult patients, there's not a whole lot, but there are a few things that really shout out and should stick with you, and this is one of them. So why does this matter in EMS? Well, because we know kids, they compensate and they compensate and they compensate until they can no longer compensate and they end up crashing on us. So it's very key that we look for these small identifiers that could tell us that this child is in shock before they actually get to that point to where they are crashing on us, because by the time they crash on us, we know as providers we are way, way, way behind the 8 ball. So it's important that we look for the little signs, the small signs that are telling us, hey, this child is already in shock, not waiting for that the low blood pressure, because once we find that low blood pressure, then we are behind the 8 ball. So the subtle signs are key. These are also patients that we don't have very often. We don't see them a lot in the field. So they're high stake, low frequency calls, meaning there's a lot at stake with these calls, but we don't see them very often. So that leaves us feeling unprepared. So let's take a quick look at shock. So shock is hypoperfusion. A clinical pearl for EMS, when we have a child that has tachycardia and poor perfusion, we're going to automatically think hypovolemic shock until we are proven otherwise. So these are our 4 buckets that we have when it comes to shock. We have distributive, obstructive, hypovolemic, and then cardiogenic. The ones that we typically see the most are going to be your hypovolemic as well as your distributive. We do see obstructive when it comes to trauma, but not as often as we see the other 2. Cardiogenic, that's a problem with the pump itself, and normally the parents are going to be able to tell you, yes, my child has a heart defect, and they should know the history. So distributive, the most common with this one is probably going to be anaphylaxis, but sepsis is one that we don't often think about with pediatrics. Our kids present with lots of different fevers, signs, and symptoms. My 4-year-old Susanna has been running a fever off and on for about a week now, spiking up to about 104. It is not sepsis, but it could develop into sepsis. So we always want to keep that kind of on our radar, like could this child actually be in septic shock? The hypovolemic shock is one of the more common, and that's because our little boogers are not great with keeping stuff down sometimes. They have vomiting, diarrhea, excessive sweating, things like that that can occur, which do lead to hypovolemic shock. So, wrong button. So with our pediatrics, the pathophysiology, so why is it so different? So they have a higher metabolic demand in their little bodies. They also burn energy faster. They need more oxygen and glucose in order for this to occur. We already have limited glucose stores as it is, and they have less reserve, which means they decompensate quicker. So they're compensating until boom, everything is depleted, and then they completely crash out on you. So they compensate with their heart rate and with their respiratory rate, not with their blood pressure. So tachycardia is one of those first red flags that we are going to see with our pediatric patients. So if we have a child that has had distress, has tachycardia going on, and then we start seeing those increased respiratory rate or the increased respirations, that should also be a red flag. Their blood pressure may stay normal, and that needs to be a takeaway, that just because their blood pressure is normal does not mean this child is not already in shock or decompensated shock. These little signs that we spoke about briefly, that's going to be tachycardia or poor capillary refill. So anything greater than 2 seconds is going to be a red flag. Cool extremities, are we not perfusing to our extremities? Is everything already starting to shunt? Altered mental status, what does that look like for this little booger? So what does a baby present like whenever they have an altered mental status? Well, maybe they have not been feeding properly, they're irritable, they keep waking up throughout the night, they have a behavioral change of some sort. They don't necessarily have to be lethargic. By the time they're already lethargic, boy, you better load and go and get them to the hospital after some fluids and possible other means. But these little boogers, if they become irritable, that also could be an altered mental status. So keep that in mind. So here's our field management for pediatric shock. We know oxygen, keep them warm, the basics when it comes to treating shock. With fluids, 20 is our magic number. 20 milliliters per kg, up to 60 milliliters per kg can be repeated. Also, we have limited glucose scores, so double check that blood glucose. Don't roll into the ER without that blood glucose being checked. So we also are going to consider if they have anaphylaxis. Our number one medication, of course, is epinephrine, IM injection, that's a 1-to-1. And then if we do need a pressor, what is our number one pressor for pediatrics? Epinephrine. Our bodies as peds tolerate, and they work off of epinephrine based on our children, they are heavy on the cardiac output. So these are our types of medications that we use for our types of shock, with the number one being epinephrine. So I love this little quote, and I put it up here. So epinephrine is the Swiss Army knife of pediatric shock management. It is fast, it is versatile, and uniquely effects at supporting both our circulation and the airway in the moments that do matter most. So our two things that we really use it for when we're talking pediatrics right now, we can use it for respiratory as well, for racemic epi, but we're talking septic or cardiogenic shock post-fluid resuscitation. So we've given our fluid bolus, they are still not perfusing the way that we want, they are still not quite, we don't have that response, then we're going to our pressor for epinephrine. So these are our doses and our range. And then we also are talking anaphylaxis, and our dose and our range are here. So what is it about epinephrine? So why does epi work for pediatrics? Well, what does epi do in the body? We have inotrope, chronotrope, and it's a vasopressor as well, correct? Which increases our boom, boom, boom heart rate. We also have cardiac contractility, vasoconstriction, correct? So kids rely heavy on that cardiac output, as we mentioned before. That's how they maintain their perfusion. So we have a heart rate and we have squeezing that's going on. So epinephrine is our friend. That is what's going to maintain perfusion for our little bitties. So after our fluid has been maxed out, then we are considering our epinephrine. So it is a rapid working medication. It has a quick onset, and it's also easy to titrate. So why are kids so scary? All right, you are dispatched out for a 56-year-old male, severe difficulty breathing. Okay, great. Let that sit in your gut. We have those calls all the time. On the flip side of things, you are dispatched out for a 3-month-old with severe difficulty breathing. Hit you in the gut deeper. These are those calls that we don't often get, and it's scary. We think of the potential outcomes. This is somebody's baby that we are now dealing with. So kids can be scary. So what do we want to do to overcome this, so that way when we are responding to that difficulty breathing with a 3-month-old child who has been in severe shock already, we are prepared. So pediatric calls are rare. They induce anxiety. Early signs are often overlooked. We see these early signs and we think there's not too much to it, when in fact they may already be in decompensated shock. So field treatment varies as well. So maybe you have a lack of resources or pediatric training. So be proactive. Don't be reactive, be proactive. Even if your agency doesn't offer tip-top training or continuing education for pediatrics, take that on yourself. So train on programs such as Hand Heavy, fantastic. It takes the work and the math out of it. You already know what you're rolling up to. You can put the dispatch age 3-month-old into your Hand Heavy app, and it will lay out everything that you need to know about this patient. Braslo is also a little outdated, but it's an option. So keep training front and center. Hands-on practice is needed. Build that muscle memory. It takes thousands of hours to build muscle memory, so keep doing the hands-on training. We do train for that worst day and hope that we don't ever see it. So here's your case. Normally I would read this out to my class, go through the process with them and let them talk it through. But what we have is a 6-year-old who has a fever, they've been lethargic, has difficulty breathing. Parents say not herself for the past 12 hours and had a fever of 104 earlier today. She's vomited once, no diarrhea, no known allergies or medical history. Don't have a lot to go on, but based on that, we can already start thinking she's probably hypovolemic. So general appearance, lethargic, eyes half closed, doesn't respond to verbal commands. That's a red flag. So skin is pale, cool extremities, cap refill is 4 seconds. That's scary. Vitals, heart rate 165, respiratory 38, BP 92/58, temperature 102, SpO2 is 95 on room air. So LOC responds only to pain, and our blood sugar is 65. This is a very sick child. I would toss this out to my class, talk about what some of the things we need to do for her are, what are some of their differentials that they are ruling out. So this baby is sick. We would do IV fluids, maintain vitals, treat for shock, keep them warm, high flow oxygen. If fluid doesn't knock out that bolus, we're probably gonna go to an epi-drip. So here we go. What does this mean for us? So for us in the field, we need to have that high index of suspicion. Having that gut feeling, that high index of suspicion saves lives. It's something you develop over time. After you're in the field, you start developing that, but start working towards it. We do have protocols from NCOEMS. Those are our guidelines. It is not cookie cutter. Just because we start down one of those protocols doesn't mean we're gonna stick to that same protocol. We may jump in between protocol, but those are our best friends. We're gonna go back, make sure that we are hitting our protocols appropriately, but just know you're not gonna get stuck in one every single time. So early aggressive management improves outcomes. So don't hesitate, treat before it's too late. So specific tools also help. Braslo, our hands heavy, are essential for our practices, for our agencies. They help us prepare. In summary, kids compensate first and they crash late. Tachycardia and poor perfusion, you need to act now. Don't wait. Early fluid, O2, IV access are critical. We're not going to assume normal BP means that they are not in shock. We're not waiting for that low BP before we act. Epi is a sick kid's best friend, and for you, my friends, study, 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 practice, practice, practice. These little kids are counting on us. We are the ones that save the day, so make sure we are prepared going in. So these are my references that I used. They were very helpful when going through and building this training, and I hope that hit all of the key topics. So have a great rest of your semester and have a good summer. Thanks, Steve. See ya.